So I will try to concentrate on the data we have on long-acting regimens for the treatment of HIV. And it's probably in the near future. We probably will have, at least in Italy, they suggest that we might have the drugs available in the first quarter of 2021, so in almost 1 year. So I just wanted to briefly discuss with you the fact that we already have long-acting drugs in other fields of medicine, such as psychiatry, in which we do have long-acting antipsychotic drugs. We do have long-acting biphosphonates for osteoporosis. We do also have long-acting contraceptives in terms of injection, but also implants that have been used in several limited resource countries for a long time. And we also have a new anti-migraine agent that has been approved a few months ago, that is can be used once a month instead of taking the pills every day or at any symptom. But I think what they have in common is the fact that patient preference is higher with long-acting agents. So usually if you ask if they like the treatment instead of taking pills, 1 or 2 pills per day, the majority of patients already on treatment like the treatment. So I think in the end it's a good, let's say, assessment of patient needs. Well, what we have available, what we'll have in the future. So we have 2 approved drugs, ibalizumab for multi-drug resistant HIV, and albuterol, but just in China. It's a version of enfuvirtide that is linked to albumin, so a very long half-life that's approximately 2 weeks. And then we have phase 3 plus cabotegravir-piperine. We already have in a phase 3 leronlimab, that is anti-CCR5 inhibitor, and we have broadly neutralizing monoclonal antibodies. We have other drugs that we just touched briefly in a few moments. I just wanted to give you an idea that the mechanism is very different. Half-life is very different. As you can see, some of these are in days, some other in months. This is one of the most interesting drugs I will touch. And also the route of administration, that is intravenously for ibalizumab, so it's a bit pretty hard to administer. Subcutaneously could actually improve it. And for example, the new drug by Gilead, the capsid inhibitors, is administered subcutaneously, so patients can self-administer these drugs. And again, that will help people to receive the drugs at home. So briefly, going to what will not change. Well, what we know about efficacy, I plot together all the studies we have. So the Latitude, the Atlas study, the FLIR studies, some in naive, some in switch studies. As you can see, the performance up to 160 weeks for Latitude suggests an 82 to 90% of efficacy. Efficacy seems to be pretty fair and not different from what we see with oral drugs. We will also have the results of the Atlas 2 that will tell us if we can give these drugs instead of every month, every 2 months. That will be a really decreased number of administration and the time people should come to the clinic for an injection. There's already a ViiV press release last summer suggesting non-inferiority, but we'll see the data at CROI, so we'll definitely see the efficacy and tolerability of the twice monthly, 2 months administration. And also wanted to put in the same slide how many patients discontinue long-acting cabotegravir-piperine for virological failure. If you see in the 3 trials, in the end, we only had 12 patients out of 900 that interrupted those drugs for virological failure. So the incidence is 1.3%, so it's actually very low. So why patients stop long-acting cabotegravir-piperine? Well, if you take a look at one of the studies, this Atlas, you see that some patients discontinue for adverse events, actually. It's 3.6% instead of 1.6%, but also other reasons are really common, and some of these reasons are not related to the drugs, hepatitis A, B, and C, while some others can be such as headache, memory impairment, and gastrointestinal problems. But they're not different from what observed in the oral drugs. So what will not change? Well, the selection of resistant-associated mutation was very uncommon. As you can see in the Latitude study, there was just 1 patient actually that developed and selected resistant-associated mutation, and no in the 2 monthly administration, but not in the other arms. So pretty uncommon. And putting together all the data on Atlas and FLAIR, as you can see, we only have 6 patients that failed in these 2 studies. And there are something that is relevant, I think. The first one is all of them were genotype A. So there's an ongoing discussion if genotype A is something peculiar in terms of favoring the selection of resistance, such as there's one mutation, L74V, that was thought to be a favoring mutation in this setting. And the second thing is most of these cases were from Russia. And so somebody suggested there could be problems with administration, delivery of the drugs. So very uncommon, and still to be understood what's the relevance and on wider scenario. So what about tolerability? Well, as you can see, the adverse events were uncommon, and if we want to go to drug-related adverse events, as you can see, there's just some fever, some headache, 3%, and fatigue. But the question I think everyone of us has is, do injection site reactions are really relevant, or they're slightly tend to decrease? As you can see, less than 1% of patients discontinue the drug because of this injection site reaction. As you can see, the incidence was higher with the first one, but lower and lower we're reducing with the following administration. So it doesn't seem to be a major problem in terms of tolerability in our patients. And this is the only data we have on weight gain, and it's not from Atlas FLAIR, it's from a prevention study, HPTN-077, in which long-acting cabotegravir was administered every 3 months to patients. And as you can see, placebo-controlled study, there's no signal of a weight increase in those patients. So I think it's a good thing. It might be different from what we observed with Dolu and BEAK and other integrase inhibitors. But I think we still need data in patients because this was done in healthy volunteers for prevention of HIV, not for treatment. So what about tissue exposure? I don't want to go into the details of PK exposure, but we know that genital exposure, both of rilpivirine in female and male genital tracts, seems to be appropriate. And so that we will be able to cover in the cervical, vaginal, slightly lower in the rectal tissue, but probably the concentration of these drugs in the genital tract are enough to prevent transmission, and that's why they're still in development for the prevention of HIV as well. There's also one data that we have on CSF, because this is one of the issues. Do we know if these drugs that are released slowly from the muscle do get to the brain? Actually, the only data we have it's in the CSF, and we see that the CSF to total plasma are very similar to what we see for rilpivirine and for cabotegravir oral drugs. So there's no difference in the percentage of drug that gets to the CSF if it's administered orally or if it's done intramuscularly. And I think this is the most important data. If you take these 18 patients in a study, of which 15 in every 2 months administration and 3 in every month, you see 100% of them had a viral load below 50 copies per ml in plasma and in CSF. There is some more movement here in patients receiving every 2 months, in which there is some signal of 3, 5, 10, and 15 copies in the CSF. But actually, we don't know if that matters, actually. But if you take the 50 copies per ml in the CSF, there seems to be a fair control of HIV replication in the central nervous system. So what will change? Well, what about treatment satisfaction? What patients say once they are in the trial? But bear in mind, if they're in the trial, they probably volunteer, they accept it, so there could be a selection bias. But patients are really happy. So they want to keep on with treatment, like 90% of them would like to go on, and there's a high percentage of patients receiving oral drugs. Actually, maybe they were not happy to be in the arm of oral drugs, but actually they want to change to something else. And also, if you measure them as numbers, you see that patients receive long-acting drugs are more happy, more satisfied with this treatment instead of oral combination. Even if you go through all the questions that we asked, you want to continue, you think your regimen is flexible, how easy or difficult it is to take your treatment, all of these indicators favors long-acting drugs. So I think patients that are on these drugs want to keep on and are happy with that. We don't know in the general population. We probably need to ask ourselves what we do. Would you take long-acting, or you prefer to take one pill once a day? I think this is a question we should ask to our patients and follow their reasons, actually. What about adherence? Well, if patient present to the scheduled visits, it's 100%. We just given them the right dose at the right time point. So adherence, if they present, is very good. One of the issues, the problems with that we don't know how to manage so far is the long pharmacokinetic tail. So once we discontinue the drug because the patient doesn't present to a visit, for how long we do have detectable levels of the drug, and on the long run it might select resistance. And actually it's very variable. It seems to depend on several features including gender and BMI that may affect how long is this tail. So patients might have different PK properties over the long term. And for example, in this analysis, again, this is the prevention study we discussed before. You see that women with a high BMI were those with a long PK tail that from a PK/PD point of view is a bit risky for selecting mutation. What I have to change actually is services organization, because we need to think how we will stop people, how we will do injection. In Italy, we're discussing how to do that, and probably we will use the STD clinics that already used to do the penicillin intramuscular injection and try to focus with them how to organize the service for having people. But it also depends if you have 10 patients, 50 patients, 200 patients. So you really need to organize it. At least in Italy, we won't be able to give the drugs to patients to do it at home. So it will be a hospital drug. So that will be relevant. We need fridges. We need fridges because rilpivirine should be stored at plus 4 degrees, and it's, at least in the EU, different from the US, the package will be separated. In the US, they will have one package for both drugs. In Europe, we'll have two different packages, and rilpivirine should be in the fridge. So we need fridges, large fridges, according to the number of patients we're treating at the moment. And we also need to find a way to remember to our patient to come for the visits and not forget those in order to not to get these tail. What about PK? Very brief, because I know it's usually boring and it's late. I just wanted to remind you that both drugs have a low potential to be victims of DDIs, and they have no potential, almost no potential of creating interaction. So what we might see is an effect of these drugs. And the good thing is that we might see less interaction with intramuscular drugs. I just wanted to point out one of the studies that was presented at EACTS by Romina Quercia that showed how well these drugs work in female in all the studies, so in Atlas and Flare. And actually the efficacy and tolerability was pretty good. She pointed out that the 4 female that were actually failing on long-acting cabotegravir and rilpivirine, well, actually 3 out of 4 had a BMI above 30. So I think this is, again, another of the things we need to study. So if there's a differential PK in female with a high BMI, and actually you see that this is an individual PK, you see that mostly at the first and second injection, they had very low concentration. So maybe in these particular patients, we need to increase the dose, at least at the first injection. Then we won't need it. So just going back to DDIs for a moment, just think that if you take a drug orally, the first thing that the drug's been absorbed finds is the liver. So most of the interaction are at the site of the liver. And so we see usually a very high first pass metabolism, so interaction there are relevant. But if you do give drugs intramuscularly, actually they just skip the liver and goes to the systemic circulation. So DDIs are usually lower. So do we have an example? Well, there's a PBPK model developed by Marco Siccardi group in Liverpool. As you can see, if you simulate the effect of rifampicin on cabotegravir, orally administered cabotegravir, the effect is really huge. There's a decrease between 60 and 75% in AUC. But then if you model the same interaction in a repeated administration of a long-acting cabotegravir, you see that the decrease in AUC is much smaller, is minus 25%. So it could be potentially, we need studies to confirm this, but it's much smaller, and maybe it can be administered with rifampicin. That actually would be a very good thing for our patient with tuberculosis. So what about new technologies? I think implants would be very interesting. They're already being used for anticonceptive drugs. They're removable. PK is not dependent on the site because they're implanted in some areas in which it's kind of constant. May remain in place for years. Bear in mind, some of those can stay for 5 years in the same place, so you don't need to replace them and if the drug is still released. However, you need a minor surgical procedure, you need some tools to insert them, and I think the development will take more time because they are both a device and a drug, so it might take some more time, but I think they might also change the future of antiretroviral treatment and also prophylaxis. There are already some data. This is a tough implant that has been studied so far in dogs, but also these are the implants, just to give you an idea, they are 4 centimeters per 2 millimeters, so they're really, really small. You can't see them. And there's also already some simulation for new drugs that can stay there with an implant for as long as 1 year. So it will be a fantastic prophylaxis in this setting. And I think the future is micropatches. Micropatches are these super small cones that can be covered with drugs. And once you leave there for some time, it can be 1 hour, 2 hours, it depends on the drug absorption of the cones, they remove it, they're not painful at all, and in the end they release subcutaneously the drug. So it's a very fancy way of administering a drug. As you can see, this is how they look like. So it depends on the surface, depends on how much drug you need to be absorbed, but they're really, really small in certain settings, so really nice to be used. The other thing is that we are combining cabotegravir with rilpivirine because it's the only drug that at the moment is able to be formulated as long-acting, but we know that rilpivirine is a drug with a low genetic barrier to resistance, and so we probably would like to have another drug as a companion drug. But the development of this drug is much earlier than the others. I think one of the most interesting one is islatravir, is the new name of the MK-8591 by Merck. It's a very potent nucleoside reverse translocator inhibitor, so it just doesn't allow the translocation of RTI. It seems to be very potent at very low doses, and this is the one studied as an implant that can stay for 1 year if released slowly from the implant itself. Even orally can be administered once a week. So very promising drug. We need to see the phase 3 studies before giving a judge. Well, broad-spectrum monoclonal antibodies are really interesting in the setting in certain setting of cure, but also prevention. And just to give you an idea, some of them are really potent and wide, so they can inhibit a lot of HV viruses. Just to give you an idea, ACTG is conducting now a study in which they're combining long-acting cabotegravir with one of these broad-spectrum neutralizing antibody as a maintenance strategy in a suppressed HIV-positive patient to see what's going on over time, if they can control HIV replication on different sites, and if it allows to reduction in HIV reservoir. The last 2 companion drugs, potential future companion drugs, are one is a CCR5 monoclonal antibody. I think it's really interesting because it was tested as a monotherapy. So they had patients with R5 virus, they're suppressed for at least 1 year, and they just use it in monoclonal antibodies, administered every 2 weeks subcutaneously, and see what happened. And actually, with the highest dose, 86% of the patients were suppressed up to 6 months in monotherapy. So I think it's really, really interesting to see what the future development. There's certainly a dosing issue because with the lowest dose, 50% of patients failed. But with the highest dose, I think it's a really interesting option in the future. And finally, this is the newest one, presented last CROI and last EACS. It's a capsid inhibitor by Gilead, and that seems to be very long half-life. As you can see, it's up to 24 weeks, and it's administered subcutaneously, so easy to deliver even for patients at home. So, where are the gaps? I think we have a lot of data. There's a lot of studies ongoing. There are at least 15 ongoing studies trying to focus on this issue. We still don't know about the tail. We still don't know about DDIs with these models, but we'd like to see what's going on in patients. What about every 8 weeks for every patient? We still need to see the Atlas 2 data and CROI. What about high BMI? I want to see a few data on high BMI patients before being totally comfortable with these patients. And what about subtype A? What about pregnancy? Children, adolescents, there's a study there. There's also a study in less adherent patients. You think that would be great for less adherent patients if they come to visit. So there's a balance between non-adherence and non-persistence. So we don't know which is the best candidate in terms of adherence at the moment. There's already one data presented last ID week in which they estimated if patient doesn't present to a study visit here, you see, almost after second, third, or fourth injection, almost all of them had very good levels of long-acting of cabotegravir. If they don't present, they simulated at 1, 2, 3, 4 weeks how much drug was enough in those patients. As you can see, when you proceed with further injection, the amount of drug that is still there is very high. So at least after the fourth injection, you can have a delay of up to 8 weeks, and still 3/4 of the patient will have enough levels of cabotegravir. So it's reassuring somehow. You might have some delay. That's a good message. And also they simulated what would happen if you give a single oral tablet of oral cabotegravir the day they miss the visit. So if they don't come on the visit the day 0 and they start taking oral cabotegravir, as you can see, the bridge is pretty cool. So you can bridge this period of non showing up, and patients have a very good PK profile. So and after they come back, they can resume the normal injection over time. It's a model, but I think it's a good idea knowing. So we should probably have some reserve of oral drugs to give patients in case they don't show for their visits. So, in conclusion, I think long-acting antiretrovirals will be a game-changing introduction in terms of possibilities, patient preference, alternatives in certain situations like gastrointestinal problems, difficult adherence. I think they probably will increase patients' preference and potentially even quality of life. The effect of the stigma effect, not having to take a pill every day, not having your colleagues, your friends to see that you're taking pills every day could be important for some of them, but some others don't want to go to the clinic every month or 2 months. So patient preference may change in a single individual in front of us. I think there are still a few issues that need to be addressed in the clinical practice. A lot of studies are coming, and I think we'll get answers to all these questions. One of the things for organizing our clinic is should we propose it to everybody? Should we wait patients to ask for this? Or which is the best way of getting these drugs into the field? And I think the last point is that I think the new technologies will definitely improve the efficacy and tolerability of this long-acting and helping our patient to keep on with the treatment of HIV. Thank you.